Good morning, everyone. Welcome to today's TIRO by MD's webinar. My name is Camilo Gonzalez Velasquez, and I'm honored to be your host today. Where we will explore a recent publication on clinical pathologic characteristics of pediatric follicular variant of papillary thyroid subtypes, a retrospective cohort study presented by Dr. Zubair Baloch, a leading expert in thyroid pathology. Dr. Baloch received his medical degree and PhD in Liquid Medical University in Pakistan, and he completed his pathology residency in the Hanuman University Hospital and fellowships in surgical pathology at Memorial Sloan Kettering Cancer Center and cytopathology at the University of Pennsylvania. Currently, Dr. Baloch is a professor in pathology at UPenn, and he has authored over 200 peer-reviewed publications and co-authored several books. Notably, he helped rename the encapsulated follicular variant of papillary thyroid carcinoma to NIFT-P. Dr. Baloch's expertise in endocrine and head and neck pathology has made significant contributions to the field, and we're thrilled to have him present his group's important findings today. Joining us as a discussant is Dr. Stephen Waguespack, a professor at the University of Texas MD Anderson Cancer Center, where he holds joint appointments in the Department of Endocrine Neoplasia and Hormonal Disorders, as well as pediatrics. Dr. Waguespack is uniquely board certified in both adult and pediatric endocrinology, providing him with a broad scope of expertise that spans across the age continuum. Since joining the MD Anderson faculty in 2002, Dr. Waguespack has consistently been recognized as American top doctors for cancer endocrinology. His clinical research interest focuses in thyroid cancer, hereditary endocrine tumor syndromes, and pituitary tumors. He's played a pivotal role in shaping national guidelines, serving as the ATA task force that revised medullary thyroid cancer guidelines in 2015 and co-chairing the inaugural ATA guidelines for pediatric thyroid nodules and differentiated thyroid cancer. He's currently leading the revision of the ATA pediatric guidelines. It is truly a privilege to have these two distinguished experts today, and I'm personally really excited about this presentation. Before we begin, just as a quick reminder, I would like to invite all of our audience to tune into the Voices of Wisdom podcast. We recently launched a podcast where we go deeper into the conversations on thyroid cancer management and pearls of wisdom in thyroid cancer management with top thyroid cancer experts. So here you can scan the codes, listen to the podcast in your favorite platforms. And now, please join me in welcoming Dr. Zubair.
Okay, thank you so much for the introduction. I'm really honored to present a publication that I was part of. This was spearheaded by the Children's Hospital of Philadelphia group, which includes really eminent endocrinologists, surgeons, radiologists, and even and also pathologists. So these are my disclosures in brief. But before I start this public presentation, I really want to take this time to really thank my mentors, which I have worked, some of them I have worked directly with and have learned so much from, and some just by reading them. So, but I was lucky to really have been, my whole career has been really because of them. So this is the article that we'll be discussing that was published in 2022. I know Camilo used the word recent, but there, as we know, in thyroid pathology, and I think this is very exciting times in general for endocrine pathology because so many things are changing. So it's really important. So yes, it is recent, but a lot has been already changed since 2022. And I think this change is going to be published in the guidelines, which coming from American Thyroid Association. But I'm going to go through some introductory remarks about it, which is also included in this article. And I think it's very important to understand the timeline, how these things change, and why there are still some controversies and a lot of discussions that happen around these, and especially around pediatric thyroid pathology and the tumors which they form follicles or follicular pattern, whether they are invasive or not, or whether they have nuclear features of papillary carcinoma or not. And that really devises the diagnosis. But we are lucky that the new classifications of thyroid pathology that are coming through have really kind of taken away some of these controversies, but they still exist. So when we historically look at the term follicular variant of papillary thyroid carcinoma, we really can form a great timeline. And this study was published actually. It's an amazing review that was published by Dr. Rani Hussain from Memorial Sloan Kettering, who's an amazing endocrine pathologist and especially thyroid pathologist. And he really charted out the course, how the names have changed, how we got used to using some names. And it was you can see from 1950s to really 2016, where the whole term of non-invasive follicular tumor with papillary-like nuclear features, which used to be called, termed as carcinoma, kind of changed. And this is like really gives you this really remarkable timeline on these two articles, one by Dr. Lindsay, who really put forth this follicular pattern tumor with nuclear features of papillary carcinoma. And this was termed as follicular variant of papillary carcinoma by Dr. Rosai in 1977. But when you read this article, the tumors that they were describing were infiltrative lesions. So it's really interesting that when you read these articles in detail, you recognize what type of tumors they were talking about. And like really in a span of 2 decades, pathologists changed their diagnostic emphasis from growth pattern to nuclear cytology. That became very important. And this really related to the FNA diagnosis when you looked at these nuclei and you can make a diagnosis of papillary carcinoma by examining a small group of cells. And papillary carcinoma, whether it had papillae or it was just recognized by not by its architecture, but by its growth, by its nuclei. So the growth pattern really became a little subdued, and we were all focusing on nuclear cytology. And the definition was of papillary thyroid carcinoma that it is a malignant tumor of the thyroid gland, and the diagnosis is based upon nuclear cytology, and it is in the 2004 as well as in 2017 WHO classification that is still current, but we now have 2022 WHO classification, and hopefully the book will be published in early next year. And when we look at the nuclei, which as a cytopathologist, I'm also a cytopathologist, we really focus on these major diagnostic features, how these nuclei look. And I don't need to go through the list, but this is really well known to the clinician as well as to the pathologist. Now, when we talk about follicular variant of papillary thyroid carcinoma, I think it had a really good clinical relevance. That papillary carcinoma tended to show lymphatic spread, and this happened both in the gland, thyroid gland, as well as the lymphatics, which was mostly the local or regional lymphatics. The follicular variant papillary thyroid carcinoma also tended to show lymphatic spread both into the gland and into the lymph nodes, but this was a unifocal disease, and it really, when you're looking at these pure cases, we realized that some of them actually went beyond lymph nodes, and the lymph node involvement was not as extensive or not as common as we saw in the classic papillary thyroid carcinoma. And just going back, it was assumed that this behavior is kind of related to the nuclear features. But infrequently, pathologists also noted that some tumors which grew like follicular carcinoma, encapsulated pushing invasion, vascular invasion, yet they had nuclear features of papillary carcinoma. And then we started to kind of subclassify these tumors. We looked at these tumors which were infiltrated, they were encapsulated. That means they were non-invasive, and then they were invasive. So they were their invasion was similar to follicular carcinoma. And then we went and further split them as having a growth pattern of a larger follicles. They were diffusely follicular, or even we applied the same criteria to the smaller tumors. Now, this is actually the infiltrative version of follicular variant of papillary carcinoma, which is an infiltrative tumor. This does not have a capsule. It has a fibrosis, and it really can be associated with lymph node metastasis as well as distant metastasis. The molecular pathology really opened up the view and showed that these tumors often have BRAF mutations as well as RET PTC mutations. So they were actually similar to the papillary thyroid carcinoma, which is the classic and its subtype. Now, the encapsulated subtype, you have to remember that even classic papillary thyroid carcinomas can be encapsulated. And this is just one case which is showing you this really encapsulated tumor with the cystic growth and the papillary formations and these gorgeous looking nuclei of papillary thyroid carcinoma. The encapsulated variant, we realized there were tumors that had invasion, that they invaded similar to follicular carcinoma. That means the tumor capsule invasion or vessels, or they had no invasion. And this is actually where the whole controversy came. And then because we focused on so much on the nuclear cytology, you are going to have some observer variability. But this is actually one of the classic cases of follicular variant of papillary carcinoma, which is actually encapsulated. And you can see there here, in the inset, you can see beautifully, this is the capsule here, and this tumor is invading into its capsule, is sitting within a vessel, and it has beautiful nuclear features of papillary thyroid carcinoma. But what this literature was showing, that the tumors which were encapsulated, we still call them follicular variant of papillary thyroid carcinoma. They did not have any invasion. These tumors were actually behaving similar to follicular adenoma. And we're talking about tumors that were well sampled. And really, we examined most likely the entire capsule of this tumor. And this really changed the whole thought process by the TCGA data, which was based upon the papillary carcinomas, and it divides these tumors into infiltrative, encapsulated, and the BRAF-like tumors, which have beautiful, gorgeous nuclei of papillary thyroid carcinoma, and RAS-like tumors, which were follicular pattern. And it included follicular adenoma, follicular thyroid carcinoma, and even these non-invasive follicular variant of papillary carcinomas and encapsulated follicular variant, which showed invasion. This really, all this data that was collecting as well as the observations led to this bigger change in 2016, where the diagnosis of encapsulated follicular pattern lesions was based upon nuclear features as well as invasion. And now the invasion has become very important. And even we are teasing out what type of invasion is. If it's only capsular invasion, these tumors still have very low risk. And some of the pathologists are calling these tumors of uncertain malignant potential. So this is my depiction, which has been actually published, and you can see the follicular carcinoma on the left side, which does not have nuclear features of papillary carcinoma, which is invading into the vessel. And when you have nuclear features of papillary carcinoma, the non-invasive tumor follicular pattern is NIFT-P, and the infiltrative is the follicular variant, which is invasive. These diagnosis criteria were revised, and the revision was that the no papillae was allowed because there were few publications which showed that if you do not have a pure follicular growth pattern, and if you have a focus or one or two foci of papillary formations, that these tumors are going to metastasize. And this is really fast forward to the 2022 WHO classification, which really takes into account the clinical risk of these tumors. So the low-risk neoplasm includes the non-invasive tumors, and this is the thyroid tumors of uncertain malignant potential, which may have some sort of capsular irregularity or capsular invasion, but that invasion may be just confined to the capsule, and the hyalonizing tubercular tumor. So this is the first time that a pathology classification was really together in form of molecular pathology as well as the clinical features of these tumors. And this is really has been beautifully shown that this spectrum of low risk to high risk tumors for these follicular pattern neoplasm really matches with the molecular profile. So I think this is a great merrymaking of molecular pathology as well as what we see on pathology. These tumors also appear as low risk on radiology. And as we know, this really helps out with the radiologic stratification. Cytology, majority of these are just called neoplasm, Bethesda 3s or 4, some as Bethesda 5, because these are encapsulated tumors and their nuclei may not be that obvious in some areas of the tumor. So this all really comes together. So this is based upon this, when you look at the pediatric literature, in 2022, there was not much available in the literature how we are diagnosing these follicular patterned encapsulated tumors, which have nuclear features of papillary carcinoma. So we looked at the database, pathology database at the Children's Hospital of Philadelphia, and the final cohort was 42 cases. And this is, again, a retrospective study. This is not a prospective study. And then we're looking back at the slides, we came up with 36 follicular variant of papillary thyroid carcinomas because they were infiltrative or invasive. And then there were 6 NIFT-Ps, which was non-invasive, based upon that these are adequately sampled cases. So these are the histologic features, and then you can see the genetic alteration. So these are the criteria that are applied actually into in the adults, and this is what the literature will show you about this. I do want to mention that for NIFT-P, there was absence of necrosis, lack of well-formed papillae, samoma bodies, or BRAF mutations, because that excludes the diagnosis of NIFT-P. And the follicular variant of papillary carcinoma was invasive, encapsulated, which actually on low power just looks like a follicular carcinoma, and then the infiltrative lesions. So this is actually from the paper, and it shows you here. I tried my best to get this picture here, but you can see this is a NIFT-P, which is an encapsulated tumor and have nuclear features of papillary carcinoma. This is more of an invasive tumor, which is invading its capsule, going into the surrounding thyroid. And this is more of an infiltrative tumor, which does not have a tumor capsule. So looking at this cohort, now how these were really preoperatively called by FNA. As I said, majority of these are going to end up into the Bethesda 4s. Actually, one case was even called benign, which is actually known. That's why when you're looking at the Bethesda classification, even the newer, latest version, the benign risk of malignancy for a benign cytology diagnosis is 0 to 3%. So that's the nature of the beast, because you're looking at the very small number of cases. One of them was called suspicious, but when you look at the follicular variant of papillary thyroid carcinoma groups, which includes invasive and infiltrative tumors, you can see some of them were even called malignant, actually more of the infiltrative type, which really which is true, because these tumors likely are BRAF-driven tumors or fusion-driven tumors, which have these beautiful nuclear cytology, which is readily identified actually on cytology. Now, when you look at the features of invasive, encapsulated, and infiltrative follicular variant, you can realize there are differences in the amount of vascular invasion. When you're looking at a focal, which is less than 4 vessels, extensive, which is greater than 4 vessels, I do want to point out that this is like only few studies which focus on this, but this really needs a further workup in the future. And then ATA risk level, so naturally the encapsulated tumors, most of them are going to fall in the ATA low risk. And when you look at the ATA risk level for the infiltrative component, is going to be from low to high risk tumors. So this was really important because this really matches what we see on microscopy with the clinical presentation and risk label. When you look at how they were treated, again, this is a retrospective study. The radioactive iodine was administered in about 50% of the cases in invasive encapsulated ones, and infiltrative ones was like 73%. When we look at the molecular alterations, 8 of the invasive encapsulated one had point mutations. And when you look at the fusions, they were more in the infiltrative follicular variant. Now, this is something that has been in the pediatric literature, and it's coming out in more studies. When you look at the pediatric thyroid carcinomas, the genetic alterations tends to be more on the fusion side as compared to point mutations, which are more common in the adult. So this story is developing, and I think it's really important for the pathologist, which I am, and not a molecular pathologist, to really keep up with these type of changes. Now, this is a comparison. Now, again, this is 2022. The majority of the data that is available is in the adults. But when you look at the pure pediatric groups, there are limited studies. And as you can see, our findings were not that far off from what was published in the pediatric age group. And I do want to make sure that when we are looking at these studies, you really have to look at how these tumors were sampled, which is a very basic concept. But as a clinician, which includes the endocrinologists, surgeons, or radiation oncologists, whoever you are, but when you're treating these patients, the pathology, part of that pathology report is very important. How these tumors are sampled and how the diagnosis was made. Because if a tumor was not completely sampled, at least its capsule, you may not have the full picture of these tumors. So that's why for NIFT-P, the capsule really needs to be examined for invasion, as well as the tumor for any formation of papillary, which still remains controversial. So this is a retrospective study which really showcases the alignment of histologic stratification. And I have to tell you, we knew this for a long, long time, that the tumors which are encapsulated, whether they have nuclear features of papillary carcinoma or not, or some things which look like papillary carcinoma nuclei, and there's a lot of variability in the diagnosis, we all agreed that these tumors are basically behaving in a benign fashion, which is now came to 2016 as NIFT-P. So I think they have a similar risk stratification as you see in adults, and it's based upon the invasion really has the whole clinical course, whether it's infiltrative or it's a vascular invasion or not, and how many vessels are involved. And I think these findings are very similar to what you see in adults. So they're really multi-center. So this was 2022, but after that, there are many other studies have been published regarding this, where the follicular pattern tumors have become a focus in the pediatric population. So I put these up here, and then some of these working groups which are working on this. So I think if you have time, please look over these references, because they really bring out some of these really follow-up, and which is basically the same findings. So I think this is really an exciting time in thyroid pathology, because we have a great merrymaking, and I think we are getting really shoulder to shoulder the histologic diagnosis, how these cases are managed, and it really reflects to the molecular profile of these tumors. So this is my last slide. Thank you so much for your time, and I am going to stop sharing.
Thank you, Dr. Baloch, for this incredible presentation and a historical perspective of what has changed. And this is just beautiful. We're going to just go right ahead with Dr. Waguespack's presentation, and we'll come back for a little bit of discussion and Q&A at the end.
All right, good morning, everyone. And thank you, Camilo and THANC, for inviting me to discuss this very important paper. And Zubair, thank you for a wonderful overview for us non-pathologists to get our minds wrapped around all the different classifications. So I really do appreciate that, as I'm sure the audience does. So I've been asked to discuss this paper. I only have one disclosure that's not relevant. So what I'd like to do over the next 10 minutes or so is just really look at this paper critically. What are the strengths and limitations of it? What's the same? What does this paper at least confirm from what we knew in the literature? And what's novel? And most importantly, how can we take these important data and apply it to real-world clinical practice? So I found this picture. I'm a very visual person, and I found this very helpful to understand the different classifications, both for the tumors, follicular pattern tumors that have papillary nuclear features, as well as those that do not. because I think, again, as an endocrinologist, sometimes seeing the path report is a little bit confusing. And so it's very helpful to see this visually. And Zubair, of course, explained this very nicely, this kind of spectrum in papillary, in follicular pattern neoplasms with papillary nuclear features from NIFT-P all the way through infiltrative follicular variant papillary carcinoma. So strengths of the study are certainly, this is a high volume center, well known and well respected in the pediatric thyroid world. Tumors were all re-reviewed and classified according to the newest WHO classifications by 2 separate pathologists. And that's a big strength of this study. This is actually, I didn't look at the other studies since then, but up to this date, this was the largest pediatric study specifically looking at this issue. And it's a contemporary series, which allows us to incorporate, or the authors to incorporate, some molecular data as well. And many of the patients, we did have molecular testing results. Of course, there's always limitations, particularly with retrospective studies. You know, although this is the largest in the literature, overall, there's still smaller numbers. And so we have to take the comparisons with a little bit of grain of salt, given those small numbers. But hopefully through efforts like the CAT-C and multi-center studies, you know, these things can be confirmed. The disease status at 1 year was used as an endpoint. And I know many of you on the group know we've talked about this before, but it's really not the most ideal endpoint, but it's what we have most readily, particularly in pediatric patients. And understanding many patients, the average age of diagnosis is around 14. So unfortunately, we don't have a lot of long-term follow-up on many of the patients who are diagnosed in their late adolescence. So we do need longer-term follow-up. The follow-up for the various groups here, median was 2.3 to 3.4 years. So it'd be great if the authors could, you know, provide an updated study in the future with longer follow-up to show that this difference continues to stand. And one thing, I think there may be a little bit of selection bias here. You know, 19% of these patients had been previously treated for another cancer and were being prospectively monitored, I would presume, with neck ultrasonography. And if you look here at the NIFT-P group, actually, it's interesting, the median tumor size was 0.95 centimeters. So to me, I think that suggests perhaps some of these tumors were picked up on prospective ultrasound screening. So we have to be aware there might be a little bit of a selection bias here. So what's the same? You know, this group previously published one of the first papers looking at just follicular variant papillary carcinoma. And so this study builds upon their experience. So basically, we know that the FNA biopsy is usually going to be indeterminate when you have a follicular variant papillary carcinoma. Most of these tumors are going to be unifocal. It's most often a non-invasive tumor when classified as follicular variant. I mean, that's not separating encapsulated versus infiltrative, but just in general, follicular variant papillary carcinomas tend to be less invasive than classic papillary carcinomas. And the concept that lobectomy may be sufficient in select cases of follicular variant papillary carcinoma. So what's novel about this study? Well, I think what really strikes me is, and as Zubair pointed out, encapsulation is a major distinguisher for clinical behavior in follicular variant papillary carcinoma. In addition to the moleculars, that's a whole separate discussion, of course, that also adds on to the risk of that particular tumor. But we have to think more about whether tumors are encapsulated or not and what that implies in terms of risk. And importantly, the infiltrative follicular variant papillary carcinomas pretty much are just like classical PTC, and we should think about them the same way. And this study adds to the growing thought process of using all of the preoperative data, specifically the ultrasound findings, as well as perhaps somatic oncogene analysis, if you have it, to help actually predict what is the invasiveness of this tumor. And more importantly, in my opinion, what's the risk of distantly metastatic disease in this particular tumor? And that can guide surgery planning. So if we look at it and kind of put together my understanding from this paper and the literature, is we have the low-risk tumors, which are the NIFT-Ps, where we don't see lymph node disease, we don't see distant metastases. And these tumors are primarily going to be associated with RAS pathogenic variants. And then next, we have the invasive encapsulated follicular variant, papillary thyroid carcinoma, where you will rarely see lymph node disease. And in this cohort, there was one who had N1A disease. And we don't see distant metastases. And these tumors are primarily also associated with RAS, but also we, at least in this study, have seen DICER1 alterations. And then they were very rare. I think there was one patient each with a BRAF V600E and one with an interesting ALK fusion. And then we have the infiltrative follicular variant papillary thyroid carcinoma, where you're more likely to see the lymph node disease as well as the distant metastasis. And this is the classic molecular pattern of being fusion-driven followed by BRAF V600E. So how do we apply this to clinical practice? So if we see a child who presents with a lump, and this is their ultrasound, you can see this is a very well-circumscribed tumor. You can actually see the halo around it, suggesting that this is an encapsulated tumor. There's no other really high-risk features that are seen on ultrasound. So the thought is, well, if this is greater than 1.5 centimeters, probably we would go ahead and biopsy this. But what we're going to expect after biopsy is that we're going to get a Bethesda 3 or 4 diagnosis. And so we have to also be prepared. Is this someone I'm going to want to be prepared to actually order molecular testing on as well? And then if you have that data to put it all together, you can say, okay, I've got this low-risk looking tumor and I have a low-risk oncogene identified. Then this is a patient who really just can be treated with lobectomy alone. If we find a high-risk molecular driver, BRAF V600E, or a fusion, then, okay, I know this is a cancer for sure, and I'm going to do surgery, but if I just choose to do a lobectomy, I would also ask my surgeon to do an ipsilateral central neck dissection, because understanding the underlying genotype predicts, or knowing that would predict if it's high risk, they're likely to have central neck lymph node disease ipsilaterally. Or you could choose to do a total, again, with perhaps the ipsilateral central neck dissection. Now, this is all assuming that there are no lymph nodes identified preoperatively. This is assuming that the patient just has the nodule and no lymph node disease. And many of us now, even with a high-risk oncogenic genotype, are actually still choosing to do lobectomy in these cases. So this was a great paper, I thought, and important to add to our knowledge. And so the take-home points is, I just turned the numbers around a little bit, but at a high-volume pediatric thyroid center over the course of a decade, we see very few NIFT-Ps. It was 2% out of their entire population. And then you can see here the prevalence of invasive encapsulated follicular variants, and then the infiltrative follicular variant PTCs. So, most of our cancers will still be the classical PTCs. So I just wanted to show at least the prevalence here as seen at CHOP. For the encapsulated tumors, we're going to see more indolent behavior. And of course, for the infiltrative tumors, we're going to see more invasive features. And as Zubair nicely pointed out, this is similar to adults. So one of the areas where maybe it's more similar than different in patients with thyroid cancer based on age. And I think really where we're at now, it's important to incorporate those ultrasound features and molecular findings if you have them, particularly in these well-circumscribed nodules, so that we can perhaps do more a directed surgical therapy to cure the cancer, but not overdo it or put the patient at undue risk for unnecessary surgery. So with that, I will stop. And I thank you for giving me the podium and letting me share my thoughts on this paper.
Thank you, Dr. Waguespack, for your presentation. I would like to start with some questions that I have myself, and I would like to encourage the audience, if you have any, just send them into our Q&A function, and I will get to them after this. So I'm going to go to ultimately, I'm gonna go to the clinical side and how we change our practice with all of these new findings. But I'm gonna start with what are your? I understand the nature of the studies, and this is by no means a criticism. This is a monster body of evidence that starts, and like Dr. Waguespack was mentioning, when you get to a point in science first, it naturally comes with a bias. Like there's no way to do the perfect study that first time around. So what are your future steps in research in this field, Dr. Baloch? What do you think is the necessary next step in research to clarify and ultimately come back to that clinical aspect of should we de-escalate treatment in such thyroid tumors?
I think one of so I always go to the basics. You can hear me correct, right, Camilo?
Yeah.
And I think one of the basic things, as I was pointing out, that once you take that diagnosis, as a diagnosis is made, the clinician should also look at how this tumor was sampled. That is very important. Because you still see some of the studies popping up here and there where they say the diagnosis was NIFT-P, but the patient had a one lymph node metastasis and stuff. And then when you go back and you look at this pathology, the way it was done, it's never mentioned that the entire tumor capsule. So this is very important for these encapsulated tumor, how they were sampled and how the diagnosis was made, because the criteria for me have to be strictly followed. And that is the first important step. I think the next one, the future of this is very hand-to-hand with the preoperative cytology that is being done, naturally radiologic stratification. But I think the radiology and the mixture of cytology, and if you add plus minus molecular studies, it kind of gives you a guide what you're going to be dealing with. That's why most surgeons are even doing just lobectomies for these tumors, which appear as a unifocal disease, nothing much worrisome on radiology, FNA, and then you add a layer of molecular. I think the controversy that is still kind of exists, and I think we have kind of crossed a little bit over, is should we be calling those tumors which have invasion into the capsule only, that now we call some of them as well-differentiated tumors of uncertain malignant potential? That is another nomenclature. Should we be calling these carcinomas, or we should just go to, we know these are low-risk neoplasm, but there hasn't been any validated long-term follow-up study, which we know, which was pointed by Stephen, that it's very important that these tumors should have a longer follow, because thyroid tumors, especially encapsulated ones, are going to grow very slowly. We know by molecular profile that these are just RAS-driven tumors with a very low allelic frequency. They do not have a layering of other molecular stuff. So for me, that is very important. And also the clinicians have to be kind of aware of it. And I think this is where the studies are needed, where, by just defining something pathologically doesn't, I think, cut it anymore. You have to have the whole multidisciplinary kind of approach to something in these studies to really make sense of it, because at the end point is the patient, which is the ultimate client, right? That's what we are treating. So I think this is where it really needs for these low-risk neoplasms. Like, I have seen cases which have been called NIFT-P on the report, and you look at the slide, and then you look at the FNA, and it has RAS, plus it had other fusions and this stuff. So how this tumor was sampled. So I personally, the bottom line is that we need multidisciplinary studies which really bring in all this data together to make sense, because I think that should be the approach for the future.
So multidisciplinary studies, and you were mentioning for one, and then you were mentioning how the tumor was sampled.
Yeah.
Is there any, I'm gonna say this, checklist, or is there any way to prove how it was sampled from the clinician side? What are the basic elements of communication, or the basic elements that a clinician should know and potentially ask and discuss with a pathologist to know, one, if the tumor was sampled correctly, to guide the treatment in the future? Yeah, go ahead.
No, it's fine. So when your line diagnosis is encapsulated or invasive, follicular variant of papillary carcinoma or follicular carcinoma, right? And then it says, it's an encapsulated follicular pattern tumor, and then the diagnosis is follicular adenoma. And then you're looking at the gross report, and let's say it was a 5-centimeter tumor or 4.5 or 6 centimeter, and there was only 2 sections or 3 sections were submitted. There's a problem, right? Because the invasion is focal, including the invasion through the capsule out or invasion into the vessels. So, you have to kind of question whether, you have to ask, I mean, to me, that's a problem, right? So just noting that, saying that, okay, the whole entire tumor periphery or majority of it was sampled and looked under the glass. I'm not saying that the pathologist should have 40 slides to look at, but you can, those sections from that capsule can be put into one block, multiple of them. So I think that's where it becomes very important, because that's where the literature gets really muddied, especially in the clinical literature, which is popping up that these encapsulated tumor, no invasion, there was METs. And you're like, well, it doesn't make sense. So I think that that's where, those are the basics before even looking at the molecular and all that other stuff, that this tumor, or you saw something on radiology and it was like, okay, there's some kind of infiltration, posterior infiltration and stuff. And the pathology report just says completely encapsulated tumor, follicular adenoma. There is something that is missing, right? I'm not saying all the cases, but those basic things, very simple things, by reading a gross description, not just reading the blind diagnosis, for me will be very helpful for the patient.
And if I can add from the clinician perspective, as Zubair pointed out, so, the multidisciplinary team approach is very important. So, it's important for us clinicians to reach out to our pathologist if we have any questions. So if I get a follicular neoplasm of uncertain malignant potential, sometimes I'll even ask the pathologist, can you go back and do deeper cuts? Or, I want to be sure we're not missing an invasive tumor. So it goes both ways. And so I think all of us in clinical practice should feel free to reach out to our pathologist, and who are always happy to show us even under the microscope what they're seeing or not seeing. So.
Yeah, because you're telling the patient you're basically fine. You don't have to worry about this. This is done. We don't need to treat you anything else. So I think you have to be 110% sure that, that treatment is going to stay.
Or if the clinician has a concern that the pathologist doesn't know about, right? Then it's important for the pathologist to know, well, I'm really worried about this tumor because of this reason. Can you look at it again with that thought process?
I think this is really interesting point that you're bringing up. The study itself, it has that, as you mentioned, that 1-year follow-up endpoint. And being that we're speaking about a pediatric population, and here, Dr. Waguespack, your insight is really, really interesting, because you see both sides of the picture. You see the pediatric and the adults. But most of us don't do that. So I recently had the luxury of having dinner with Andy Bauer and asked him, what do you do as patients transition to the adult world? And there's a million different points of data that could be missed or overseen when the transition happens. And for that, we need definitely a longer follow-up. So what's the deal? What do you need? Why is this, for example, these elements of importance in treatment, why are they not in the pathology report, for example, or systematically added into, I mean, the number of samples? How do we take decisions in the follow-up of these patients?
Yeah, all that stuff is in the pathology report. It's just, I think many clinicians don't know how to find it or what it means. Right, Zubair?
Yeah, but the thing is, you do not even have to read you may not have to just read the line, but there's a synoptic part of the report. When you're calling something cancer, and now the College of American Pathologists, actually the synoptic report even includes NIFT-Ps. The low-risk neoplasms are included in that. So I think it's important I personally, as a pathologist, maybe I am not that smart. I work on a feedback. So somebody has to tell me, ask me questions, and then my thought goes on. So, you're doing the same thing over and over again every day. And it is interesting, but you need that feedback. So for me, that's why the multidisciplinary approach is excellent, because I learned from your end how these things are being monitored, treated, or even investigated. So I think the pathologist also needs to be on its toes when the clinician is asking, this, but there's something that is not, not being cohesive. Naturally, there are cases which happen, but in the main stuff, this doesn't make sense. Or can you please look? Can you please, did you sample the whole capsule? Stuff like this. Or this patient had a BRAF mutation and you're calling it a NIFT-B. There's a problem. Was this the nodule that was biopsied? So these questions are not bad. They make us both learn. I mean, that's my thought.
Exactly. This is what I was worried about, because when you're speaking of MD Anderson, UPenn, you name it, MSKCC, you have the whole team in place. But as most patients are treated in the community, there's important elements in this discussion that are missed or overseen sometimes. So that, for example, that question you were mentioning, is this the nodule that was sampled? Do we have an FNA result? Do we have a molecular result that can better help us understand the biological behavior of this tumor? How do we close those gaps, especially when you go out to the community, when we step out of what I call the ivory tower kind of treatment?
Yeah. Steven?
Yeah, no, I agree. So there is a question, Camilo. Should I go ahead and take it?
Please do.
So the question is there any role for TIRO score and size of the tumor for the surgical plan? And so I could just give you my perspective on that. So in my mind, TIRADS really just helps us understand which nodules need to be biopsied or not. It doesn't really translate to a surgical plan. And size of the tumor is a very controversial area right now. We're actually debating that right now in the pediatric guidelines about whether or not, for example, tumors over 4 centimeters, just based on that size, would warrant a total thyroidectomy. And I see Zubair shaking his head too. And so our approach is that we know that most children with tumors over 4 centimeters will actually have clinically obvious lymph node metastases. So it's a non-issue. But in those where there's no obvious or preoperative evidence for lymph node disease, then we would still do a lobectomy in that setting, particularly if it looks like an encapsulated tumor.
Yeah, I mean, I think that goes for NIFT-B also, because when you have the initial study and the follow-up studies think that they can be as large as up to 6 centimeters. That's from the Memorial data. Naturally, that's in adults. So I've seen these tumors to be very large sometimes. Follicular adenomas can be also very large, especially the ones which are oncocytic. They can be also very large. So I don't think the size really, because sometimes you can see a very aggressive tumor being like less than 2 centimeters. So that happens. So I personally think the size in this case should not indicate, unless what you pointed out, the other features.
So it's a good segue, because I actually had a question for you, Zubair, because I noticed in the paper, actually, the invasive encapsulated tumors were actually larger than the infiltrative tumors. Now, it wasn't statistically significant, but any thoughts on why they are, or why they were bigger?
I don't know. Really, I think that's the cohort. Yes. Also, remember the infiltrative tumors are, so when you're looking at an infiltrative tumors, you're looking at basically what you look at gross tumor size on a gross examination versus what you're looking at microscopic, maybe little difference in there, because this tumor, when they infiltrate, they do infiltrate in the surrounding thyroid parenchyma. They are unencapsulated lesions. So the measurements may kind of differ in that sense. Plus, they may have tumor nodules away from the tumor. So I personally have very hard time really kind of compiling what I see on the microscope versus on the gross. So I always give an estimate of the size, which was seen, and I make sure that this kind of matches for what we're seeing on radiology also. But I've seen infiltrative tumors to be small. Sometimes they can be small, and these larger tumors growing with a capsule and just like growing by pushing borders and the capsule, so they can be larger. So I don't have a great answer for you, but that's what I have seen. That's the nature of the beast, because they can be multifocal, actually, the infiltrative ones.
Zubair, looks like you have a question from Jonathan. I don't know if you can see the question and answer.
Given the role that you've stressed for molecular testing, particularly for confirming low-risk lesion, how do you feel about we be stratifying lesions with lower sonographic concern for molecular send-outs, given incomplete access for testing, financial access?
Yeah, I think what molecular adds is a layer of so I think it adds a layer of how this patient's, what type of surgery, which I've seen, at least in my center, is being done, lobectomy versus total thyroidectomy, or at least a little bit more, and then sampling of the lymph nodes. I personally will see if a tumor had a RAS mutation plus a TERT promoter mutation, and it's an encapsulated tumor. I will make sure that I really examine all the sections, and even in the areas of suspicion, I can do more deeper levels to make sure I'm not missing something. Also, the center of tumor to make sure that there's no transformation. Now, in the lower financial resource setting, I mean, this is always the question that, these molecular tests which are available, they are very expensive. And naturally, the patients is not going to be paying $3,000 plus money out of pocket. But I think the more tests we do, the lower cost of this test will be. The example being HPV testing for pap smears in cytology, which is basically very low cost, and it has proven to really be good for the low resource setting. But there are some key markers that are available by immunohistochemistry that can be done now, even in pathology, like BRAF has immunohistochemistry. RAS has immunohistochemistry. RAS is not going to tell you whether it's malignant or not. Some other markers, like the proliferative markers. So I think there's a lot can be done without having that FNA molecular data. But I think at this point, the ultrasound has become so good, and I really sometimes am shocked how specific it is in a lot of cases. So if you have a nodule which appears as a unifocal disease, there's no invasion, at least gross invasion, which is mostly seen on the ultrasound, and you have a Bethesda 4 or 3 diagnosis, you are going to be dealing with, most of these are going to be low-risk tumors. Granted that the sample was really examined, the FNA sample, they exclude the presence of necrosis, they exclude the presence of any, nuclei, funny-looking nuclei, and they're calling it that. And as we know on the follow-up, most of these are RAS-driven tumors, and they're going to be either follicular adenomas, minimally invasive follicular carcinomas, or minimally invasive follicular variants, or NIFT-Ps. So I think I will say 60+% of the cases, the radiology and that low risk type of features on cytology, really charts out the course what you'll be dealing with, because that's what happens. If the opposite lobe is totally normal, there's no lymph nodes, it's a single lesion as 7-pointer, you're not going to push that patient to have a total thyroidectomy. So there's a lot of data that is already available. What molecular does, it kind of refines that. And sometimes you rely on it prospectively a little bit more, but I don't think it's something that is needed in all cases. I mean, that's what I think in my experience I've seen.
Okay, so there's a new question from the audience that says, in writing new guidelines, have you been concerned that the preoperative knowledge of lymph node metastases may be highly subjective, specifically in community-based care setting in non-high volume settings? Thinking of instances where the lateral neck is not even imaged, evaluated, or sometimes even central neck is not evaluated, or instances where clinicians may not look at images themselves, but rather just the radiology reports. Interesting.
Kevin, that's for you.
Yeah, no, thank you, Amber. And I think you're correct. So we do have a lot of concern in the pediatric community about these, patients not getting adequate preoperative assessment, and it's not uncommon. Even now in 2024, that kids are going to surgery without biopsy and without comprehensive neck ultrasonography to really try to look for any evidence of lymph node disease, which we know is going to be extremely high in children presenting with a thyroid nodule and thyroid cancer. So, I think part of our our vision for the whole community is that more of these kids get to centers that have more expertise in this, but understanding there are financial limitations to that across the country. So, but you're exactly right. And so when we present this kind of algorithm, or what I presented, that's assuming, right, a lot of things, that the neck ultrasonography was done by someone experienced, that it included the lateral necks. And so very important point you bring up. Thank you. I do have a couple of quick questions for Zubair, because I want to learn from an expert while I have him on the phone. So tell me the deal with partially encapsulated tumors and what that means or doesn't mean. And do you think NIFT-TP is a precursor to invasive encapsulated tumors? If it's sat there long enough, do you think it would become that?
You're now digging a hole for me. So I think naturally the tumors have to start somewhere, right? And when you look at the mutational profile of these tumors, they have the basic mutational profile is RAS, and most of them are NRAS, right? When you look at, as your aggressive pathologic features are there in a tumor, like vascular invasion, extrathyroidal and stuff, you start to see layering. You either see the gene expression profile come up, or there are copy number alterations more on these tumors. So I think, and we're talking about non-oncocytic tumors. The oncocytic tumors is a totally different ballgame. They are the ones that really, I think, are interesting and totally different animal. But for me, when you're dealing with something like this, I think personally, I think yes. A long time ago, there was a whole push of saying, we do not have a concept of in thyroid, like an in situ carcinoma. What we use that for, I think, and we kind of barely think about those when you're talking about in the C-cell lesions, right? The C-cell hyperplasia, we always see is the precursor to medullary thyroid carcinoma, because you have that stuff available to really follow. So I definitely think that the follicular adenomas, by these molecular profiles, we know that something happens that triggers, and there is, and naturally we see more allelic frequency of the RAS mutations, plus we see layering of other things. So they definitely start like that. Suddenly definitely there's not 100% answer, but I personally think yes. Partially encapsulated. One has to be very careful when you use the term partially encapsulated. So let's take a papillary thyroid carcinoma, which is infiltrative, and then you see this kind of fibrous rim around it, about 1/3 or 2/3 of the tumor. I have to be very careful to say that there is partial encapsulation, because these tumors do create a host response, which is a fibrosis, right? Which usually you see either in the middle of the tumor or mostly at the edge of the tumor. So you have to be very careful you're not overreading that fibrotic response around the periphery of the tumor as partial encapsulation. In the grander scheme of things, why does it matter whether it's partially encapsulated or not, right? If it's infiltrative, either have nuclear features of papillary cancer, it is an infiltrative PTC. So for me, I'm very concerned about this partial encapsulation, because to me, it's really, yes, if I see something partially encapsulated, I can tell myself it's a true capsule. I am going to go back into that block, do deeper, and make sure that the other component that I'm seeing is not encapsulated. Is this not an invasive component that I'm saying that this is partially encapsulated, it's a benign nodule? Yes, you do see it. I mean, in the setting of follicular nodular disease, clinical multinodular goiter, you do see adenomatous nodules, which have a thin capsule. But you have to be careful when you're dealing with cancers to use that terminology. So for me, why does it matter? It's infiltrative, it's encapsulated.
You're going to go with the worst finding anyway.
Yeah, I mean, so for me, I don't sometimes even I don't actually, may have, but I basically avoid that term.
Yeah, great, thank you.
And I'm not saying that that's the norm, but that's what I'd rather keep things clear and make it easy for myself. I'm a very lazy person, so I try to keep it like, okay, this is it, this is not, as long as I can do that.
Beautiful. So we're already over past the hour mark here. I want to thank both of you for just a very insightful presentations. I want to thank our audience for being here. again, and hopefully to see them back next week. I want to encourage everybody to go to the Voice of Wisdom podcast and listen to the episodes that we have so far with active surveillance and unexpected surgical findings with top of thyroid cancer experts. And I want to invite you to be back next Friday to discuss active surveillance of differentiated thyroid cancer metastatic cell cervical lymph nodes with Dr. Leonardo Barbie Walter following up next week. So everybody stay safe. Thank you for being here, and thank you for your time.